So, but let me start. Dr. Blight, very impressive work on MR. I myself, I'm a radiologist, and we get a lot of these MRs. And one of the things we find difficult is trying to segment out the tumor. So what kind of software did you use? I'm kind of interested to know. Because you mentioned that you marked out 1 in every 8 slice, and then the computer, I guess, went ahead and segmented out the rest of the tumor. Could you just elaborate? Maybe we can replicate that work here.
Yeah, so we spent a long time with different softwares trying to work out which was best. I think we started with some kind of widely available Mac software called Cyrix, which
yes.
you'll have known. So we used the Cyrix, which the tools were just not good enough to make those sort of drawings and kind of grow the regions around that complex shape. So we now use Mirion, which is French. It's from Paris. So I don't know if you read the Frauenfelder volumetry paper in the ERJ 10 years ago. They'd used Mirion Intrasense as a kind of, and so it allows you to do those sort of techniques.
Okay. Thank you. Yes, we have a question.
This is for Dr. Simone. In the palliative area of treatment for mesothelioma, can proton beam be shortened to 2-week intervals? I mean, to have the patient drive into a unit for 6 weeks for, X amount of rads on that. Is there, just like they're doing for breast now, BID for 2 weeks, etc. Can the proton beam intervals be shortened?
So in essence, yes. Protons can be, 1 day up to however many days. The issue is generally the lower the dose we give, and in palliative settings, we generally don't need to give a lot of radiation. So the side effects of radiation then are relatively low. So the potential benefit of protons over photons is going to be pretty minimal in that setting. As we start to treat the higher doses with the intent of either shrinking the tumor or making the tumor go away, we then need to treat larger doses of radiation, sometimes larger volumes. Those are where we start to see a lot more of the side effects, and that's where protons can have an edge over photons. But when we're just talking about a 2-week palliative course, generally, the large majority of patients can have equally good treatments with protons and photons. So if it is a question like that where you have to drive from far away, I would say to get the radiation closer to home with photons.
I also have another question. In the salvage setting, do you usually, the standard therapy, you just give the patient radiation, or do you try to refer the patient for cryotherapy first?
Good question, especially if it's more diffuse pleural, but one area of the pleural. We've used things like spray cryo, where we'll treat a region of the pleural. But if it's an isolated area, we're generally doing the stereotactic radiation.
Mm-hmm.
And when it's larger than that, we'll do a more definitive radiation.
Dr. Blight, I'm curious because we have a lot of patients who end up getting like 8 thoracenteses, and they just never get to somebody who's going to look in their chest. So I'm curious, what's your experience with how fast you can get to somebody and look inside their chest and make a diagnosis?
Sorry, I just deafened someone over there by kicking the desk. Yeah, so that story is a heart sink. So a large part of our program is designed to try and find patients with meso early on in the diagnostic pathway. There's no point in pleural fluid aspirations, maybe one to make sure it's not lung cancer or infection, but if you're asbestos exposed with a cancer on CT, you should just have a thoracoscopy, in my opinion. So we have, I guess our pathway is quite aggressive. So if you have an effusion and you're asbestos exposed and the cause isn't obvious, then we'll put a scope in.
I agree with you entirely. Do you have an educational process? So primary care physicians or other people, you know, who see these patients maybe before you do they get educated that if they have to do more than just one simple thoracentesis, you know, for a potential inflammatory effusion, and they send them right away? Is that a big problem?
We've got an educational program that we try and roll out through the national network, but the education is not that they should refer everyone, because you know, thoracoscopy is not available in every centre, and there are 40 centres in the UK. So really what we need is some sort of imaging or blood test that highlights the patients who are likely to have meso, who present with an effusion, and then refer them. At the moment, we have to accept that we will see a lot of patients in clinics, but we may be able to try and sieve out those who don't have meso. But in the absence of an objective way of finding those patients, it's quite difficult. But I think there is education to be done around don't do repeated taps, don't do Abrams pleural biopsy, closed pleural biopsies, which are just horrendous and are rubbish. So those are important education points to.
And this, you mentioned that if you do a biopsy and it's negative, then you follow them for a year just to make sure they don't have, you know, a cold disease that shows up later. How many of those patients actually do end up coming back with mesothelioma? Do you have any idea?
So in diaphragm, we of the 165 mesos that we had, only less than 10 were picked up through that 1 year follow-up process. So very few. But it is important that is done, because we know that if you've got asbestos exposed with an effusion, you're in that group of benign asbestos pleural effusion, whatever that means, and certainly 10% of those will get meso within 2 years.
The other question is, you have many patients where you diagnose mesothelioma, but the MR gets basically a 0 tumor volume. It's so early you can't actually see anything on the MR.
I think that's one of the challenges for the MR at the moment is, I think so we've not found that in our population, but I think if you had a volumetric method where you just drew round the pleura, so we've got a 2-step process where the operator draws round the pleura, but then they have to then segment within that mask based on a signal intensity range that we know from our perfusion studies corresponds to cancer as opposed to benign pleural disease. So we've, by definition, not had anybody with 0 numbers, but I think if you, the very early stage meso patients, there is no appreciable tumour, and that's a problem, because then our oncology colleagues won't treat them because there's no measurable disease. They've got an effusion that you've drained and nothing happens.
It's a good point though of, you know, imaging will potentially underestimate volume all the time. We actually, similar question to what you asked, we looked at 3 different softwares and we compared what the software showed for each imaging, and then we took out the samples surgically, and it was just an extended pleurectomy decortication. So in theory, all the thing that came out was tumor. There wasn't normal tissue out with it. And consistently, all 3 imaging modalities underestimated tumor in all but like 2 or 3 patients that we looked at.
And Dr. Simon, you know, since, I mean, your ability to do the whole pleural radiation with protons is pretty impressive. And we've been doing, you know, it's kind of standard what we call tomotherapy for years, and that works out actually pretty well. We have 3 different sites that we have all can do that at, so we can get it done in Southern California pretty reasonably well. But some sites, and this is variation between different, I don't know all the details of doing radiation therapy, but some sites have much higher incidence of, say, you know, ipsilateral pneumonitis, you know, and we've had a few patients where we've done pleurectomies, and then they end up with a big portion of their ipsilateral lung, you know, involved with pneumonitis, severe pneumonitis. And I don't know what all the issues are in terms of of that kind of a problem and whether protons can really impact that, because it seems like you can more narrowly focus them, so that why not, I'm going to play devil's advocate, why not just do it on all patients post-op? You know, other than maybe the ones that are really early that have no nodal disease and have, you know, really T1 disease in the truest sense. Why not just do it to all those patients? Because, you know, most people are still dying of localized disease, and you can still impact potentially on their survival.
Yeah, I agree, and this is something we're sort of debating internally. I think for the non-node positive patients where we're already getting a 7-8 year survival, those ones, you know, is radiation going to help them that much versus, you know, while generally protons I do think are better tolerated, I mean, there is always a chance of a fatal complication from radiation itself. So I think for those patients, no, but yeah, I think we spend a lot of time trying to identify the high risk patients, but you know, maybe the intermediate risk patients we should be doing routinely too.
That's why being able to treat the fissure using proton is really impressive. You can actually really carve out and be able to treat into it without toxicities.
Although, interestingly, Joe and I and a few other people have all noticed that getting the tumor out of the fissure surgically is the easiest part of the operation. So it comes out very nicely. So it's, you know, we've had very few fissural recurrences in our patients, and so the fissure doesn't seem to be a particularly difficult area to control surgically, but certainly some patients do get recurrences, so it'd be nice to be able to kind of at least extend it into the fissure a little bit.
Dr. Levsky?
I have a question. When a lot of times when we give the checkpoint inhibitors, we see pneumonitis. We see pneumonitis because it's one of the immune effects. So have you seen, for both of you, have you seen more pneumonitis when there are checkpoint inhibitors with radiation?
First, we haven't seen more than what we're seeing with checkpoint itself. And that's true for all the side effects. We're not seeing any more, because checkpoint also can be seen to be a radiosensitization agent. So for a lot of brain tumor patients, you know, you won't touch it with radio if they've been given checkpoint. But we're not seeing any more rashes. We're not seeing any other side effects from checkpoint increased because of the radiotherapy addition.
Yeah, I mean, 2 weeks ago I would have said the same exact thing, and that is the right answer for sure, in my opinion. You know, the Pacific trial in lung cancer was just updated and published this week in New England Journal of Medicine. So we generally think these PD-L1, PD-1 inhibitors, their pneumonitis rate's only 3 or 4, or almost 5%. And the timing and the mechanism is different than radiation, so they shouldn't be additive as far as pneumonitis risk. 2 weeks ago, I actually had a patient though, and you know, we're doing it kind of indiscriminately, radiation and immunotherapy, usually sequentially, but sometimes concurrently, and I haven't been worried about pneumonitis for the last year or two. I was very conservative back in 2015, but not as much now. But 2 weeks ago, I actually had a patient that was one of those patients that finished whole pleural radiation 9 or 10 months ago, sailed through it, no complications at all, got 1 dose of immunotherapy, and within a week had a grade 4 pericarditis and a grade 3 pneumonitis. So I mean that's very extreme for just PD-L1 by itself. So there probably had to be some type of recall synergy in some way with those patients.
I have a question regarding your timing. If you do like a pleurectomy and then chemo and radiation is coming at the end, or does it, you know, typically, or do you do it the other way around?
Yeah, I mean, I like doing the radiation first because it is a local disease, but it seems the field is moving more and more to chemo after surgery and then radiation at the end. So, yeah, in an ideal world, if I was sort of writing the book, I would do radiation first, but we're generally doing chemo first.
Yes, go ahead.
Sorry, I just want to ask about the process of being trained to use these proton therapy equipment for those centers that are using MIRT. What are the kind of training and rigorous process to even change into a proton therapy? Just kind of understand.
Yeah, I think every
Is it
center.
just like a new software that they have to learn, or they have to go through a certain experience?
Yeah, it's a completely different machine. So I think every center is doing things differently. I mean, proton therapy is relatively new technology. When when we got it at University of Pennsylvania in 2010, there were only 5 other centers in the country, and now there's 27. So the technology is proliferating, but I mean, generally a single room proton center is about $30 million versus a single room photon machine is on the order of $2 million. But each center that gets it is in charge of sort of their own credentialing. There should be some type of standards, but there's not right now.
Because I mean, we focus on referring patients to well-trained radiation oncologists who specialize in mesothelioma. And I was just wondering, with proton therapy, do they have to have a certain years of doing these therapies, or just more like learning a new machine, a new protocol or software to kind of go through these?
Some centers are very rigorous, but others are not, and that's a very good point. I would infinitely rather a patient go to a center that uses tonal therapy regularly and has excellence in it than a random proton center that only treats 1 or 2 mesothelioma patients a year. That patient's going to do infinitely worse.
Great. What about insurance? Is it authorized by insurance company with proton therapy versus the tonal therapy?
Depends. I mean, most mesothelioma patients are over 65. Medicare always covers it, and then the private payers it depends on the region. Different regions cover it in different frequencies.
Thank you.
I think at $30 million, they better train you. Yes, go ahead.
This one's for Dr. Simone. You have one slide there where you talked about this proton process in conjunction with chemotherapy. Do you know anything about instead of chemotherapy in conjunction, but one of the immunotherapy drugs like Opdivo or Keytruda, and what impact that might have had on the PD-L1 situation?
Yeah, so that's what I was trying to hint at the end of the talk, that I do think there are radiation of all kinds. You heard a great talk in the last talk that the radiation and these immune drugs can be synergistic. There's some very preliminary preclinical evidence that protons are probably a little bit more synergistic with them than photons, but I think that the potential of any type of radiation with these drugs is pretty high.
But the radiation in conjunction with an alternative drug, like you say, you're talking about Alimta and cisplatin?
I'm referring now to the immunotherapies, the PD-L1 and PD-1 drugs.
Oh, okay.
I skipped over one other slide, but
Yes.
even gene therapy, it looks like we've had a lot of synergy with radiation and gene therapy too, more so than we would see in our institutional experience with gene therapy alone. So I think radiation has the potential to really hone the immune system in a sort of elevated state where now the immunotherapy can come in and do its job a little bit more effectively.
If I can just add on to that, one of the things that came out of the MAPS-2 trial, even with their the really good results for 44% of just any kind of response, was that the microtumor environment was kind of like, they're like, if we could just get more into the microtumor environment, and nothing messes up a microtumor environment like radiotherapy. Proton, photon, doesn't matter. Just destroying that really can change that kind of effectiveness of those compounds. Yeah. It's true. It removes it.
One last question. We have lunch. I just want to ask Dr. Wilson. You didn't show much in terms of dose effect. So on your effects with your tumor model and the Tregs and everything else that you have, did you test different doses and see is there a specific dose that below which the effects are missing?
For the checkpoint, you bring up a very good point. For the checkpoint dosing, that came out of trying the different doses to see a response, where we were seeing no responses and where we were seeing some responses. We didn't look at the T cells, both in the microtumor environment or even some of the TCR repertoire stuff we're doing with the bloods in those non-responders. We just said if it's not responding, we're not going to look. But one thing does come out of it is scheduling. Scheduling has become apparently, and this is in every trial that's being published right now, before, after, how long does priming take? Does priming make it worse for some compounds? Is it better to treat after? More so than anything than dose has been scheduling, has been seen as different effects.
Do you have any thoughts on that? Which one's the best way
We're definitely seeing for anti-CTLA-4 at least, pre-radiotherapy is where we're seeing the best results, hands down. And that's probably going to have to do with by pre-dosing those Tregs, right? So they're already going to be inhibited before you even get in there. You can make a logical argument for both before and after for the other ones, but with PD-1, a lot of other trials have shown that it's less effective before.